This is a case of a 54-year-old female presented with about 1 year of pain, essentially right over the pes bursa region in her right knee. Most of her pain was essentially with stair climbing. This patient essentially had a ganglion cyst emanating from Hoffa's fat pad, and it basically was right over her pes bursa. I drained the cyst. We got about 3 cc's of thick, clear fluid, and then injected with cortisone. This procedure did provide significant relief for her, and the swelling also did diminish after this procedure. Here we are focusing on the anatomy. We can see this ganglion originating from Hoffa's fat pad and then basically traveling distally and medially, where you have a fairly large lobule right over the pes tendons, essentially, as they insert on the proximal medial tibia. Here's our probe. It's in an anterior sagittal plane, and our needle essentially is going to go right under the probe. And the needle will be in a long axis view on the ultrasound screen. And here we are aspirating this ganglion, and essentially we're able to get just about all the thick fluid out of this ganglion. And here we are now starting a cortisone injection with the hope that perhaps the cortisone will prevent recurrence of the ganglion. And thankfully this patient had a pretty good clinical result from this procedure. This is a case of an infrapatellar fat pad ganglion aspiration. Patient is a 54-year-old female with pain in her knee for about a year. She had pain with stairs and some swelling over the proximal medial tibia. Here's a sagittal MRI where you can clearly see the ganglion at the inferior aspect of Hoffa's fat pad tracking proximally. Here's an axial view where you can see it right medial to the patellar tendon. And then as you go proximal, you can see it track within the Hoffa's fat pad and underneath the patellar tendon. Here we are in a coronal oblique view, and you can see the ganglion right over the pes tendons. And we're just going through the medial and lateral aspects of the ganglion. Now we're in an axial view, and we're just looking at the inferior and superior aspect of the ganglion. This is a fairly smooth ganglion with some lobes, but not too much irregularity to it. Here we are, we're anticipating where our needle is going to head. We're just pushing on the skin with an iodine swab. The ganglion is fairly superficial, pretty easy to get to. We used a 22 gauge needle here, which, looking back, I would recommend using an 18 gauge or even sometimes a 16.5 gauge, just to make it much easier and quicker to aspirate the thick fluid from the ganglion. Fortunately, in this case, we were able to get just about all of it. Here we chose the larger of the two lobes, and I would always recommend just going for the larger lobe within these ganglions. Little reverberation artifact there you can see. Also, one important thing about ultrasound is that it allows you to keep the tip of the needle within the actual fluid of the ganglion or whatever cyst you're aspirating as the tissue collapses around it. Also, sometimes you may not be able to get any or some of the fluid out. In that case, I would just recommend breaking apart the ganglion wall with the needle, and then over time, a lot of times the ganglion will soften up and shrink in size. But in this case, we were able to, fortunately, aspirate just about all the fluid. Here's a close-up of the fluid from the ganglion. After the procedure, we injected her with some cortisone. We basically drained an infrapatellar fat pad ganglion cyst that just kind of tracked out here to this pes anserinus bursa region. We aspirated it, we injected with cortisone. Actually, it shrunk a lot, it's less painful now, doing fairly well. Seems to be pretty happy with the result. You can feel it, but you really can't see it much today. Okay, great.